Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 84, Preeclampsia. Preeclampsia is a ginormous subject, and it's one for that reason that I haven't tackled. And one of the junior doctors I work with who's listening to my podcast said to me the other day, "Have you got an episode on preeclampsia?" And I thought, it's probably about time I did, because it's a common problem. A very common problem, but with a very wide range of severity. And anything from no symptoms to quite severe symptoms and severe illness. Anywhere from 2 to 8% of pregnant women will develop preeclampsia at some point during their pregnancy. And 0.5% of pregnant women will have what's termed severe preeclampsia. So what is preeclampsia? Preeclampsia, or sometimes PET for short, usually occurs after about 20 weeks of pregnancy, so in the second half of pregnancy. And it's a combination of raised blood pressure and protein in the urine, or at least that's how we diagnose it. Much of our antenatal care is actually designed to pick this up. This is why we're obsessed when you come to clinic with having a urine sample each time. We have a little stick with reagent squares on, and we dip it in the urine to look for protein and glucose. We dip it in the urine, gaze at a little square on the strip to see if it turns green. And the degree of green tells us how much protein might be in the urine. We might call it a trace, 1+ or 2+. Actually, eyeballing it in this way isn't that accurate. So the next thing we need to do once we've detected protein is send it off to the lab to quantify the amount. This is done through the so-called PCR, protein creatinine ratio. If it's above 30, that means this woman has preeclampsia or PET. Or does it? We need to be a little bit wary because there are other things that can confound this and cause protein in her urine. For example, if her waters have broken and she's leaking amniotic fluid, then protein from that can make the sample inaccurate. Or if she's had a recent urinary tract infection or has one at the moment, there may be protein in the urine for that reason. Or it may be that she's got other causes of impaired kidney function that are causing her kidneys to leak a bit of protein into the urine. But if we don't have another obvious explanation for a woman to have protein, we have to consider that she's going to develop preeclampsia or is somewhere on the preeclampsia spectrum, even if she doesn't have raised blood pressure at that point in time. Blood pressure readings are very important. How we take them is critical. We've moved in recent years towards automated blood pressure cuffs, and these are very helpful, but they can sometimes under or overestimate the blood pressure. So there is quite a lot of guidance about manually taking blood pressures and calibrating that and checking that against automated machines. The other thing that's very important is that we use the right size blood pressure cuff. So depending on the size of the woman's arm will determine what size cuff she needs to accurately measure her blood pressure. In the first few weeks of pregnancy, we expect blood pressure to go down and reduce, so the booking blood pressure is likely to be lower than what's usually the level for that woman. This means if a woman books in early pregnancy with borderline or raised blood pressure, it's likely that most of the time her blood pressure has been significantly higher. We expect to see a gradual rise in blood pressure during pregnancy, and it's only when it gets to levels that we're concerned about that we need to perhaps instigate treatment. Some women have what's called gestational hypertension. That is, during the pregnancy, their blood pressure rises to higher levels, which may or may not need treatment, but do not have associated protein in the urine. And this is equally important to look out for, but is not preeclampsia. Despite a massive amount of research into the causes of preeclampsia and various treatment options of how we might prevent it developing, we're really very little further on than we used to be. The best I can say is it's thought to be to do with the placenta. When I was a medical student, women were being recruited to something called the CLASP trial. This was to look at whether aspirin may help prevent preeclampsia. And now, 30 years on, aspirin for potential prevention is still our mainstay of treatment. Women that we know might be more at risk of developing preeclampsia in pregnancy are started on aspirin treatment from 12 weeks. A 75 milligram dose, maybe because they've got pre-existing kidney problems, or they're slightly older age, above the age of 40, or maybe they've got a twin pregnancy, or have had preeclampsia in a previous pregnancy. These women have a higher chance of developing problems, so we'll recommend that they take aspirin. The majority of women who'll develop preeclampsia will develop it late in pregnancy, towards the end, in the 3rd trimester. One of the peculiar things about preeclampsia is a woman may feel extremely well. She may not have any symptoms. Indeed, the majority of women will be what we call asymptomatic, have no symptoms at all. She may have noticed that she's got a little bit of swelling, or that her face is a bit puffy. But this can be common in late pregnancy anyway. The most noticeable swelling may be around her fingers. We'll often ask if her rings are getting tight. Perhaps her ankles or her feet. Is she having difficulty getting her shoes on and off? Does she notice big lines when she takes her socks off? And sometimes she can get swelling actually on her tummy. At the bottom of her tummy, the skin can look swollen. There may be a gradual rise in blood pressure over a few days or weeks, and we may start medication to try and control this and monitor her with more regular visits, perhaps to our day assessment unit. In the last few years, it's been fantastic that we can now instigate home monitoring of blood pressure. We can lend a woman a blood pressure machine, and she can take her blood pressure regularly at home. This is helpful in the light of something called so-called white coat hypertension, which is where a woman's blood pressure goes up when a healthcare professional takes it or when she comes to hospital. Coming to hospital to see us may be stressful, and if she's worrying about what her blood pressure reading is going to be, it may be even higher. We will often sit a woman in our day assessment unit or clinic and repeat the blood pressure 3 times over 30 to 60 minutes, a so-called BP profile, seeing it coming down to normal levels once the stress of the situation has worn off. If the blood pressure is persistently high, then we know it's real blood pressure. It's a real problem. And it's important to be cautious like this, because if we overtreat blood pressure by giving tablets when it's not required, then we could drop the blood pressure too low, and this could have a detrimental effect on the placental blood flow. Many of the treatments we give control the signs and symptoms. I've mentioned blood pressure tablets there, antihypertensives. We want to drop the blood pressure to a safe level, and normally we use a threshold of 140/90 as our kind of cut-off range. Severe blood pressure problems are when the blood pressure reaches a level of 160/100. And if the blood pressure is persistently at this level with protein, then this is when we have a case of severe preeclampsia. But the treatments we give do not deal with the underlying disease process. Ultimately, the treatment is the birth of the baby. If preeclampsia is diagnosed at or close to full term, the end of pregnancy, then this is very simple. We can perhaps induce labour or do a caesarean if needed, without concern. But if a woman develops preeclampsia, and particularly severe preeclampsia, at a preterm stage of pregnancy, then this is far more complicated, as this may mean preterm birth for the sake of the mother's health. The only way to make that mother better is actually for her baby to be born, even if that's detrimental to the health of her baby. Preeclampsia itself can also have complications for the baby, as growth restriction, again due to lack of good placental blood flow and placental problems, can go hand in hand with preeclampsia. You would think that the more severe preeclampsia, the more severe symptoms a woman might have. And some women do come with severe headaches, swelling, maybe abdominal pain, maybe blurred vision or visual disturbances. But I have seen women with severe preeclampsia who have no symptoms at all, and this can be very challenging. I've seen women with raging, astronomically high blood pressure, extremely dangerous levels, but being unable to comprehend why I'm telling them that they absolutely must be in hospital. And this is difficult. It may mean that they don't want to come into hospital or refuse to come into hospital or take their own discharge home. Perhaps they just turned up for a routine midwifery appointment. They were expecting that everything was going normally. They didn't think they had any problems. And then after a few blood pressure readings and a urine dip, we're telling them that they're seriously ill. It can be very difficult to convince them when they're feeling totally well that actually their health and that of their baby is in serious danger. I can't prevent a woman from going home. All I can do is try and explain to her the rationale of why she needs to stay. This is often more difficult earlier in pregnancy. She may not be on maternity leave. There may be things that she needs to get in order. She may have other children at home to look after. Explaining to her that she has a potentially life-threatening complication, and yes, preeclampsia can be life-threatening, is extremely difficult. A tiny proportion of women die each year, even in the UK. 4 women died in the last triennia, the last Embrace report of preeclampsia in this country. And that's women that died from that alone, as opposed to those that died from that and other causes associated. The thing that we are really worried about is uncontrollable blood pressure leading to a brain hemorrhage and neurological damage or death. Why is it called preeclampsia? Pre means before. So what is eclampsia? Well, eclampsia is a fit, a seizure associated with that raised blood pressure and protein. Eclamptic fits are now quite rare, partly because over the course of my career, we've discovered that magnesium sulfate is a very effective treatment. Eclamptic fits that used to happen more frequently, and particularly actually in the first few hours after the birth of the baby, are rarer because we can give magnesium sulfate as a preventative treatment. If we have a woman with severe preeclampsia and we're worried about her, we will actually start magnesium sulfate to try and prevent her from having that fit. We can tell if a woman is more at risk of fitting by checking her reflexes. Normally you can test a reflex like a knee jerk with a thing called a tendon hammer. You tap the knee and you get a reflex response. In severe preeclampsia, the reflexes are what we call hyperreflexic. They're very brisk. You actually don't need a tendon hammer to elicit it. I can tell if a woman's got brisk reflexes because if I go and examine her on the ward round and I literally tap with a flick of my finger against her knee, I'll generate an immediate reflex. So women that have very high blood pressure and brisk reflexes and protein need starting on magnesium sulfate. And whilst the ultimate treatment of preeclampsia is the birth of the baby, delivery, it's very critical that we stabilise the woman first, bring her blood pressure down to a safe level, get the magnesium sulfate started to prevent her from having a fit, and then think, is induction appropriate or do we need to perform a caesarean, and over what sort of time frame? Usually we want the baby out in the next 12 to 24 hours, depending on her condition. I mentioned the fact that eclamptic fits are now relatively rare, and the ones we usually see are now out of the blue. We weren't expecting it. Maybe the woman never had any raised blood pressure. And we'll see maybe 1 or 2 a year in the average maternity unit. So the treatment when we see a seizure in maternity is very different from that in the rest of the hospital. If we see a woman have a seizure, unless we know that woman has epilepsy, we will immediately assume it's an eclamptic fit. Start that treatment to keep her safe until we can prove otherwise. Eclamptic fits are usually fairly brief, maybe only a minute or 2. And like any emergency, we start with the ABC, keeping the woman safe from harming herself, making sure her airway, her breathing is okay. The fit will resolve quite quickly and we can safely instigate our treatment. We have an eclampsia box. It has marked on it exactly what to do, how to draw up the magnesium sulfate and in what dose to give it. There are 2 doses. The first is a loading dose, a higher dose to get the magnesium well into her system. And the second is a maintenance dose. To make it easy and simple for staff, we've got it labelled, use me first, use me second. In that rare event when an eclamptic fit happens, we know exactly what to do. We grab the box, we've got it to hand. Then we start doing blood pressure readings, blood tests, dipping urine, trying to confirm our diagnosis, is this eclampsia? And although it's rare, we practice regularly. The other very important aspect of treating preeclampsia is fluid balance. That is, keeping a careful record of how much fluid or liquid the woman is drinking or having through a drip and how much urine she's passing. Years ago, women used to die because of pulmonary edema. That's water on the lungs, overloaded with fluid. This is because the protein is leaking out of their blood vessels. That's what causes the swelling. So if you imagine the swelling in your ankles and your face and your fingers, you're getting that swelling in the lungs too. All the fluid in your body is in the wrong place. So you might feel thirsty because actually your blood vessels are intravascularly depleted, so you don't have enough fluid in the blood vessels because it's all leaking out into all the other areas of your body. Preeclampsia can affect the kidneys, so we may see that the urine output, the amount of urine produced per hour, is reduced. And it can be very tricky for us to accurately balance the fluids if there's very reduced urine production, because we don't know if that's because the woman is dehydrated or not. If we give her fluid, a so-called fluid challenge, then it may just pool in her legs and tummy and not help the situation at all. Sometimes if you're doing a caesarean operation, you can see the fluid. Literally, as you cut the skin and the tummy wall, fluid can ooze and trickle out from all the swelling. So it's very important for us to fluid restrict. And where we are giving intravenous fluids, give fluids that will help the fluid stay in the blood vessels and not leak out into all the other tissues in the body. How much fluid we can let a woman have will depend a little bit on her body weight. The commonest amount is to say about 75 millilitres an hour, so about 1 milligram per kilogram of body weight per hour. That's why the nursing and midwifery staff will be meticulously measuring out how much you're allowed to drink if you've got preeclampsia. And they'll subtract from that any liquid we're giving you to give you medication. Often the swelling will get a little bit worse in the few hours after birth, and then gradually the kidneys kick back into action and she starts passing lots of nice clear urine, and we can tell that she's starting to turn a corner and be on the mend. Alongside severe preeclampsia, there's something called HELP syndrome, which stands for hemolysis, where you get red blood cells bursting, hemolyzing, elevated liver enzymes, where you get liver function abnormalities, and low platelets, where the platelets, the little cells that clot the blood, are reduced. This can cause internal bleeding in the liver, a very low blood count, and kidney problems. A woman can become very unwell. Again, the treatment is the birth of the baby and then supportive treatment, whilst we wait for her body to repair itself and recover. The body is an amazing thing, given time. Actually, there's very little we need to do. We may need to give her a platelet transfusion. As I've said, we may need to restrict fluids and give blood pressure treatment. But on the whole, over a few days, after the birth of the baby and the delivery of the placenta, the woman will start to recover. So preeclampsia is a very difficult thing to deal with. It's hard to know when you first pick up a bit of protein and borderline raised blood pressure whether this is going to be a woman that's going to have a relatively harmless, benign course of the illness, which may mean having an induction perhaps at 40 weeks, but isn't going to cause her or her baby any significant harm. Or whether this is a woman who's going to have significant illness and you really need to get on and get this baby born and prevent her deteriorating and getting really unwell. In recent years, you may have read something about a test for preeclampsia. And there are a couple of things that we can now do that are advances in medicine that have happened during the course of my career. We can screen women by looking at uterine artery Dopplers, that is the blood flow to the womb, at 20 weeks scan. If the woman has raised resistance, then that can help us predict that they have a higher chance of developing preeclampsia or growth problems for their baby. And for these women, we can organise extra appointments and extra ultrasound scans. The most recent development has been blood tests. PLGF, placental growth factor. This can be used as a once-only test in any woman between 20 weeks and 34 weeks and 6 days when the symptoms start or the blood pressure starts. A PLGF of less than 12 is very severely abnormal and tells us that this woman has a very high chance of severe disease and is likely to need preterm delivery. These women we admit to hospital. Women with a level of more than 100 are very unlikely to have severe disease and very unlikely to need preterm delivery. And so for these women, who we previously might have kept in hospital, we can now safely let them go home and carry on with their pregnancy, perhaps with some observation, some extra appointments or home blood pressure monitoring, but we really don't need to worry about these women. Women that are somewhere in between 12 and 100, do have a possibility of preterm delivery and more severe disease. So these women we need to keep an extra eye on too, but we don't need to manage quite as aggressively as those with levels less than 12. This preeclampsia test has been introduced in the last couple of years in my hospital, and it is helpful. It can help us focus our efforts on those women and babies that really need it. And like I said, can allow other women to stay at home without us worrying about them, but also without us increasing their anxiety about what's happening in their pregnancy. It can help us reassure them in a confident way. Slightly paradoxically, even though I've said that the main treatment is the birth of the baby, delivery, that's ultimately what makes the woman better. Blood pressure problems can sometimes last for some time after this. Women will remain in on our postnatal ward while we're trying to titrate their blood pressure medication against their blood pressure readings. With some women, it will disappear very quickly, but some women may need to take tablets for weeks or possibly even months, gradually reducing the dose under the care of their community midwife and GP. It's very variable how much time it takes for the woman to actually get better. I think sometimes it's frustrating to women that we seem reluctant to discharge them, let them go home, start life at home with their new babies. But this is because we don't want to see them readmitted with uncontrolled blood pressure a day or two later. Sometimes getting the medication right can be quite tricky, and often there are different medications that we can use after the birth of the baby than ones we choose to use in pregnancy. We'll try and get a woman onto a relatively small number of tablets, maybe a dose once or twice a day to make it easier for her to manage. Otherwise, we can end up with women trying to remember to take tablets at all times of the day and night, while also trying to deal with the disruption of looking after a newborn baby and nighttime feeds. Again, home blood pressure monitoring has been helpful. We can give a woman clear guidance on what sort of levels of blood pressure we're worried about and when to contact us or the GP for further support. We can enable her to monitor and manage things at home. This is far from a comprehensive account of preeclampsia. It's just my thoughts and experiences of some of the women I've seen and some of the developments that have happened in my career. The Magpie trial in particular, with the use of magnesium sulfate to prevent fits, has been a massive success story. And as a result of that trial, they also discovered that it actually has a neuroprotective effect for preterm babies. Those babies whose mothers had had magnesium sulfate were discovered to have less chance of cerebral palsy, so we're now able to use it for that as well. I can't help wondering what other advances might happen in the next few years of my career. So even though we don't know exactly why it happens and exactly how best to prevent it, we have come some way in the treatment that we can offer. So what's my zesty bit? My zesty bit is don't underestimate blood pressure. Every confidential inquiry into maternal death I've ever read has talked about people not effectively treating a blood pressure of 160 over 100. And every time I read that, I can't understand how it might be that staff wouldn't take that seriously. So if you have a woman who has that level of blood pressure on a persistent basis more than once, then that needs treatment. It's an emergency. It's a red flag. You need to get assistance. If you're a woman who's pregnant with preeclampsia, understand it's really difficult for us to predict exactly how things might progress. It's often quite frustrating to have to go and tell a woman on the antenatal ward that I don't know whether she'll need to have her baby today, tomorrow, 2 weeks' time, or actually 4 weeks. It can be a very unpredictable course. But doing the blood test now can tell us whether you're a woman that we need to keep a really close eye on, because she and her baby have a higher chance of complications. It's frustrating for women, I know, day by day. But bear with us. If you're feeling really well, but you're stuck in hospital, there should be good reason why. And don't be afraid to ask, why is it we think you need to be in hospital? And have we checked your PLGF? Is that what's underlying our concern about you? If you don't need to be in hospital, then do ask your hospital whether they have a home blood pressure monitor that you can borrow. The more you can actively help us monitor your blood pressure and keep you at home safely, the better. And if you know that actually you need a different size of blood pressure cuff when you come for your checkups, before staff take your blood pressure, remind them, actually, they usually use a large cuff on me, because that way we're going to get the most accurate measurements. I do hope you've enjoyed listening to this episode of theobspod. Feel free to contact me on Twitter at FWmaternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.